Good afternoon, all. Thank you so much for joining us on this sunny afternoon, I should say. Last time we had this session, it was quite dark, but lots changed in a week apparently. Before we begin, I would like to advise those participating that we will be recording tonight's session. Good evening, all. On behalf of Eastern Melbourne PHN and Banksia Palliative Care, I wish to welcome everyone to the Banksia GP Palliative Care Workshop Series, Management of Nausea, Vomiting and Other Palliative Care Symptoms in Community. My name is Nicole Stark and I'm the MPHAN Events and Education Coordinator here at MPHAN, and I'm also joined by Sonia Mbesi, who is the Palliative Care Program Facilitator at MPHAN. Now, I would like to start with an acknowledgement of country. Eastern Melbourne PHN and Banksia Palliative Care acknowledges the Wurundjeri people and other people of the Kulin Nations on whose unceded lands our work in the community takes place. MPHAN respectfully acknowledges their ancestors and elders past and present. In the spirit of reconciliation, Eastern Melbourne PHN acknowledges the traditional custodians of country throughout Australia and their cultural, environmental and spiritual connections to land, sea and community. We pay our respects to their elders past and present and extend respect to all Aboriginal and Torres Strait Islander peoples today. We recognise and value the knowledge and wisdom of people with lived experience, their supporters, and the practitioners who work with them and celebrate their strengths and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. Just some quick housekeeping. All attendees will remain on mute throughout the presentation. Please type any questions for our speakers in the Q&A box at the bottom of the screen, and these will be answered at the end of the presentation. A little bit about Eastern Melbourne PHN. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for the most vulnerable. MPHAN achieves this goal by improving access to essential services, commissioning services to improve health outcomes, and by supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring people receive the right care in the right place at the right time. We thank you all for joining us for this valuable information session. This event will equip healthcare professionals and caregivers with the knowledge and confidence needed to provide comprehensive care for patients experiencing constipation, nausea, vomiting, fatigue, diet challenges, and malignant bowel obstruction. I'd now like to introduce our fabulous speakers. We have Dr. Chien-Che Lin, who is a palliative medical specialist consulting in Victoria, working at various hospitals and palliative care services, including Banksia. He also serves as a general practitioner on Saturdays. His mission is to enhance the quality of life for those with incurable diseases, and he actively teaches and supervises medical students and trainees to promote academic excellence and compassion in healthcare. We have Lisa, who is a highly experienced palliative care nurse providing palliative care support for over a decade across all areas of healthcare, including public, private, and community palliative care. In addition to her training as a registered nurse in 2010 at RMIT, Lisa recently completed the graduate certificate in palliative care throughout Melbourne University. As clinical practice leader of Banksia Palliative Care Service, Lisa supports and guides a team of registered and enrolled nurses. Her roles include coordination of the care team and working with palliative care physicians to ensure clients receive timely access to palliative care support and symptom of management. And on that note, I'll now pass the mic to Dr. Chen.
Thank you. Okay, I'm just going to mute myself. Medical emergency team to Ward 8 West Gastro Unit. Okay. Yes, that was good timing. because I'm still physically in the hospital. But I'm just going to share my screen now. Okay. So, okay. Thank you all for coming to tonight's session. And thanks, Infant, for hosting and all the admin support as well. And first of all, I just want to acknowledge that while everyone's living in the community at home, we are dependent on the general practitioners to continue their invaluable care as the patient's main doctor. And we're all here to support you guys to continue the care. And really thankful for any collaboration in the past and upcoming. So tonight's topic is management of nausea, vomiting, and other palliative care symptoms. So take-home messages. First one is constipation prevention with prescription laxatives. It's often required for people living with life-limiting, threatening illnesses, especially in the setting of regular opioids. Select antiemetics based on underlying symptom mechanism and side effect profile. Fatigue is multifactorial, often refractory, and energy conservation as well as equipment provision is crucial. Always maximize dietary protein, energy intake, and potentially avoid fiber. So I will go through these in details. And people with risk of malignant bowel obstruction benefits from additional planning. So we'll start with a case example, and this case will guide us through. It is a fictional case in a sense, but certainly will be very similar to many cases that we see. So Mrs. CH is a 79-year-old Vietnamese female who came in with her son to your clinic. She is non-English speaking, but her son translates for her and speaks fluent English. So she's only been to the clinic once in the past for repeat opioid prescription, and because mostly she's had been seeing the hospital oncology team, and that but she has seen your previous registrar who diligently updated her medical history and of metastatic pancreatic cancer, gastroesophageal reflux disease, asthma, sciatica, type 2 diabetes, and dyslipidemia. She was advised to have some coloxone senna on hand. So she was reportedly told to go see her GP again. So that's why she's in your room today. After an episode in emergency department with nausea and vomiting, son had a printed copy of the preliminary discharge summary, because of course it's not completed as yet and not sitting in your inbox. That with him describing nausea treated with intravenous metoclopramide, intravenous hydration, and that there was fecal loading treated with enema and ED with one bowel motion prior to discharge. She was prescribed Maxilon PRN and advised to buy coloxone senna tablets over the counter. So, I draw these talks to be a bit more interactive, but we will have time to talk about it at the end. And but really, we need to know if she's still on the opioids, and if she had been taking her medications, and has she had further bowel motions since coming home, and yeah, has she required any more Maxilon, basically. So then you find out that she actually doesn't want to take her laxatives, and her son is ambivalent as well, because she had diarrhea from coloxone senna. They were worried about malnutrition. She doesn't want fecal urgency when going out, so common, as you know, common concern, and especially when people at the same time are getting weaker, their mobility is declining. There's functional issues when it comes to continence, and that she doesn't think she needs to stool as she's not eating much anyways. How would you advise her? So just gonna really go through. It really is that it's very hard to avoid prescription laxatives at this stage. And by prescription, even though coloxone senna is over the counter, really is that we know fruits and fluids are good, but unfortunately often insufficient. So it is often required for people with life-limiting and threatening illnesses in the setting of regular opioids. So going back to the what we know, the facts in a sense, constipation is very common. And 1/3 of normal stool comes from the bowel itself. So people can block even when they're not eating. And in fact, if they're not eating, the less they eat, the more likely people become constipated. It is multifactorial. Many may not be modifiable. If they have pain, cancer pain may need opioids because they may not respond to simple analgesia alone. So in a way, opioid requirements may not be modifiable. Setting treatment targets, having one motion every 3 days is generally what we tell people, but also that people need to feel empty and it's easy to pass and feel empty afterwards. So some people actually do feel better with more, and some people do feel they don't need as much. On the other hand, it's important to make sure something is coming out at however much frequency that the person feels they need to. And just warn that they're not the same as before because they're now on opioids, or now they are now eating less and less hydrated often. So very important to go through all that. Non-pharmacological strategies also very important. So posture, routine toileting, abdominal massage, hydration. We talked about fruits before. So fiber actually is not the beneficial aspect because fiber, they are bulking agents, as we know. So are things like psyllium husks. And bulking agents do not work without lots of fluid. Plus, they actually don't stimulate bowel motions directly, and doesn't soften the bowels, the stools directly. So what's in pears and prunes? There are natural occurring laxatives called sorbitol, basically non-digested sugar, and that can act as laxatives. So pears and prunes do work, but there are also over-the-counter products that's made from those. Just a reminder of the best position to defecate. So, and all these are important education to go through with the patients. And yes, our nurses will also support that education as well, but very important to reinforce that. So having the knees higher than the hips and being able to sit forward with elbows on the knees and straighten the spine. And yes, as you can see, footrest may be required to help with this. And having a routine stooling is also important because with reduced mobility, as people just don't feel they don't feel they have the energy. They don't think they need to go to stool, so therefore they don't go to the toilet and sit on the toilet. It's important to make sure it's a routine thing to try. So again, it comes back to opioids, and I'm sure many of you would have heard the saying, the hand that writes the opioid prescription should also write the laxatives order. So yes, all laxatives are over the counter. Saying that though, you can get increased quantity supplied by PBS for Movicol as well. So but important to remember all the different formulations because they all have pros and cons, really. So it's important to make sure we diagnose and treat fecal impaction because oral laxatives may not be sufficient to evacuate any fecal impaction. The PR, of course, would be the best, but also symptoms for overflow diarrhea is something to look out for. If people say, oh, they're actually having diarrhea, but only fecal fluid comes out and they feel like there's still something stuck up there, chances are they have impaction and have overflow diarrhea rather than true diarrhea. And in terms of treatment with suppositories and enema, suppositories are safer, and because one is you do need to apply it with the finger rather than a nozzle, and there's less chance of poking into things you shouldn't be poking into, like tumors, or simply just making perforations. And the other thing is suppositories are less osmotically stressful for the body. But of course, we know microlax is something people are very used to. Small-ish volume, but something like fleeks have higher volume and need to be watched out, especially in renal failure patients where the phosphate load can cause problems. The oral laxatives, the differences are colchicine are tablets, whereas Movicol is a big volume that you need to mix it in at least 100 mils of water, and that sometimes can be the deciding factor. Well, actually, you should say it's often the deciding factor between those two. Plus, we often use them in combination as well. And lactulose, the limiting factor often is its taste. It is quite sweet, and people sometimes also report bloating with it because of the sugar, undigestible sugar effect. So again, avoid bulk forming agents. The last agent to talk about is opioid antagonist, because methyl naltrexone is the main one that's actually on PBS. It's a subcutaneous injection that only acts peripherally, so it doesn't cross the blood-brain barrier and does not reverse the analgesia of the opioid. Now, one thing of note is, so this is quite easily available nowadays. It does require prescription, of course, and one of our community palliative care nurses can also help the patient use this and administer this. The main thing to watch out for is people actually need to be on a lot of opioids already to fully benefit from this, because again, as we discussed, constipation is multifactorial in this case, and opioids, we're talking more than 150 milligrams oral equivalent for a reliable requirement / benefit of opioid antagonist for constipation purposes. So that's not to say you're going to cause harm by trying it on someone with a lower opioid dose per day, and that might be the last kick that they need to defecate. But yeah, it is definitely not the main aspect of management. The other thing is really it's about maintaining / restoring a bowel habit. So again, coming back to aiming for how frequent it is and having the patient and the family learn how much they require and work out, because everyone actually do need to work out themselves how much laxatives they need to maintain the bowel habit is very important. So she was seen by the Banksia Palliative Care Service nurse at home, and then we have planned to see her weekly to help monitor symptoms and reinforce the use of laxatives, coming back to the need to restore that habit. And her son's made another appointment with you on request from the Banksia nurse to get repeat prescriptions to review her nausea. Now, she's being advised to take regular Maxilon 3 times a day, pre-meals, has run out of the script from ED and is taking her leftover on Densitron 3 times a day instead. And her son still says, I'm not sure the medication is working. So what else would you like to find out? And as many of you will know, we need to work out exactly what they're expecting from the medications. So, and that's the point, is working out what's the issue. So she is having regular bowel motions. There's no reports of vomiting or vertigo. There are no other localizing symptoms. Now, I've kind of withheld the true concern of the patient really at this stage and the son, but at this stage, the question will be even focusing on the nausea side. If there is a sensation of nausea, we probably would consider ordering some investigations. So potentially, depending on how well they can describe the regular bowel motions, whether we still suspect this overflow, diarrhea, or other concerns, we may or may not do imaging. But blood tests, especially things like calcium, may be worthwhile doing for someone who may still tolerate and benefit from treatment of complications as that. But the second point I wanted to make from this presentation is the selection of antiemetics, and based on symptom mechanism side effect profile. So let's assume it's nausea that they're worried about. Something to remember is nausea and vomiting don't always go together. And it'll be very apparent later, because that's classically something like bowel obstruction, where people don't feel nauseous until they're actually vomiting. Whereas, of course, people can feel nauseous without checking, and there may be nothing to come up because they haven't eaten at the time, or simply not to the severe extent that they're wanting to vomit. So it's good to work out where the nausea sensation is coming from. So there are 6 syndromes that's been described. First one is delayed gastric emptying, so medication-related, multifactorial. So as we know, neuropathies, autonomic neuropathies from diabetes that she had, we remember, but also potentially previous cytotoxics that may have added to it. It could simply be her functional deterioration, her overall increasing frailty, because of course the gut, there are muscles as well. So peristalsis itself may be slow because she now has sarcopenia / increased frailty. It can be chemically mediated. So we talked about checking out calcium. Again, opioids feature here as well. And yes, if she is currently on treatment, that would be a concern in terms of symptoms. Visceral serosal irritation, so constipation itself can feed into nausea, vomiting, and of course, malignant obstruction we will talk about later. Raised intracranial pressure, directly causing nausea. Vestibular, opioids can actually sensitize the central labyrinth as well. But yes, direct insults to the vestibular system, again, something like metastases, or the common things like BPPV or other vascular causes can, of course, lead to vascular nausea, vestibular symptoms, and vertigo, and maybe nausea secondary to vertigo. And then there's the cortical aspects. So anxiety can link to nausea, and people can also have anticipatory nausea from previous bad experiences with, for example, having had chemotherapy and have just been turned off eating so much that the smell of the food triggers their nausea. So other than the syndromes, which we'll come to, there's also the side effect profile that we use to decide on medications. This is arguably more important, especially in the setting of Parkinsonism. So, because majority of our antiemetics are dopamine antagonists, and they can cause extrapyramidal side effects. The antihistamines, which is the cyclizine and promethazine, yes, we do use phenergan for nausea at times, although it's probably less centrally selective than cyclizine. Hence, if cyclizine is available, we probably still use that over phenergan. They do both make people sleepy. The anticholinergic effects, like the buscopan, basically. Buscopan is probably more an antiemetic rather than an anti-nausea, so to speak. So it stops vomiting for sure, but it doesn't quite stop the sensation of nausea because it doesn't cross the blood-brain barrier. On the other hand, it can certainly add to constipation. The serotonin receptor antagonist, the ondansetron, of course, we all know it also constipates, which makes it semi more useful in gastro, but definitely not very helpful in palliative care patients where constipation may be already a huge issue. A broad spectrum of receptors are acted on by the agents such as olanzapine and levomethormazine. So they're antipsychotics, but we know they've been tested in chemotherapy and other settings for nausea and vomiting. They're very effective. They're both sedating, saying that the olanzapine actually, the doses used up to 10 to 20 milligrams actually have not been reported to be more sedating than placebo in people with chemotherapy-induced nausea. My suspicion is actually people who had olanzapine were able to tolerate hydration better, so they were less drowsy, probably because they were eating and drinking better. That's my suspicion, because that's not reported in the case series. But yes, but it's a slightly surprising aspect, which I do think people are prone to stay, especially in the palliative space. So I do warn people that people can be more sleepy after olanzapine. Other agents used, so octreotide is a somatostatin analog that reduces secretion in the gut and directly, so it doesn't dry the mouth like buscopan, and may help in vomiting. Steroid is a bit of all-around action, mainly used for underlying malignancy-related symptoms. The thought is it reduces peritumoral edema and inflammation. Hence, even though it may have some direct antiemetic, anti-nausea, and perhaps pain relief aspects, we rarely recommend it unless there is underlying malignancy, only because it's much more predictably beneficial in malignancy, and as well as the problem that if people are on steroid long term, they will lose muscles quicker. So yeah, it's something we reserve for that and for short term only. Benzos are actually not uncommonly used. So lorazepam itself, and we talked about the anticipatory syndromes, and that's why we sometimes do say trial some benzos for nausea. And cannabinoids is something that's been touted, and probably there are increasing data to show that medicinal cannabis probably does have some symptom benefits. It's probably still not as good as everything else that we already know. And plus, it probably works more predictably as a background agent rather than PRN. But of course, we know there's no standardized formulations, so every product's different, and supply can be an issue as well, or reliable supply can be an issue as well. So not that easy to use, but no doubt we'll see quite a bit in this population. And coming back to the syndromes, so with delayed gastric emptying, things like domperidone and metoclopramide certainly can help there. And whereas things like chemically mediated ones, making sure we do want things that cross blood-brain barrier to manage that. And buscopan probably wouldn't be much helpful if, again, we talked about it's more for vomiting anyway, but certainly we wouldn't be using something like buscopan for chemically mediated nausea and raised intracranial pressure. So coming to the actual complaint. So in fact, what they're really worried about is that she is not eating. She's getting thinner. She gets tired very quickly after visits and from friends and relatives, and she's coming with the comment she's just being starved to death. I don't understand why they couldn't just put a feeding tube in or put up a drip. So I'm sure many of you have encountered this already. this is fairly common concern. There are cultural differences, of course, but almost universally, I would say, feeding is caring in many cultures. And it is true in many aspects, but also a trigger for distress when that's not possible. So how do we advise, and what do we advise and do for her? And again, everyone provides counseling differently. The main thing to get across is that fatigue is multifactorial, often refractory, and the main management is energy conservation strategies as well as equipment provision. And that we do recommend maximizing dietary protein and again avoid fiber. But in terms of reduced amount of intake, maximizing the protein content is the key. In terms of actually counseling the situation, so I often talk about how the people are getting weaker and the reduced eating is the result of the body slowing down rather than the cause of it. Because the main concern is whether people are starving to death, and that's not true. In that we know even if we do put a feeding tube in, people do not regain weight or become stronger because they're living with cancer or other life-limiting illnesses, and they're not able to regain that function, even with invasive feeding. So in a sense, yes, it's a problem, but it's not the cause of the whole problem. It's unfortunately a result of it, and the strategies that we use to live with it the best we can, and try to slow it down as much as possible with maximizing protein intake. In terms of the energy conservation and fatigue and equipment, so energy conservation, we often use bank as an analogy that people only have a certain amount of money or a certain amount of energy that day, and they need to decide what to spend it on. I often talk about, because exercise is a big question, and we often do talk about, look, if they have the energy to exercise, great, but make sure they have enough energy to do all their activities of daily living. Equipment, again, there's a lot of, depending on who you talk to, a lot of sometimes ego involved. But what can happen is people, because they don't want to walk with a walker, they just stop walking. So it's important to remind people that it's better to walk with a walker than not walk. And of course, it's better not to have a fall. In fatigue, so it's also good to look for potentially modifiable factors. So we know anemia might be correctable. Again, a trial of transfusion or referral for trial transfusion is it's an interesting idea. I think practically, because things are often multifactorial, I think if there are reasons to go to hospital anyway, then making sure the hospital team remembers to check the HB and perhaps trial transfusion, trial one back and see whether it works. But because for people to respond symptomatically to transfusions, it takes a few days. There's the burden of going to the hospital as well. And really, in terms of maintenance transfusions for symptoms, anything more than weekly is generally thought to be futile, because they spend a few days trying to feel better, but then they will quickly feel worse again. So if they needed more than once a week, chances are they're never feeling better from the actual transfusion itself. And that's independent to, of course, life prolonging purposes, which is a different goal. Cachexia and nutrition deficiencies may or may not be modifiable. Shortness of breath is another interesting factor, because people can present with breathlessness. They can come in, they say, they're so short of breath, and that's why they came and see you. But what it really meant is they can't do anything they want to do. And the trouble, of course, is that treatments for shortness of breath, like opioids, may not enable them to do things they want to do again. So it's one side of the same coin, two sides of the same coin in terms of breathlessness and fatigue and functional decline. So working out that nuance and what's going to be actually worth doing is also important. Other things like hypothyroidism, hypogonadism, adrenal insufficiency may be correctable if they have time. So if they have more than a few weeks, in fact, a few months, then it's definitely worth checking and correcting. Metabolic disorders as well. Maybe they're hyperglycemic all the time, or maybe they're hypoglycemic because they're not eating enough, and perhaps we need to drop their medications. Pain is an important factor. Clearly, again, painkillers add to the fatigue, but pain itself also adds to the fatigue. So talking about appropriate use of pain relief is important. Certainly, we don't want the pain to stop people from participating in their daily activities. If they're not sleeping because of pain, we certainly should be managing that. There may be primary insomnia, secondary insomnia as well, and so managing that. And depression, emotional distress, many additional support. And treatments, of course, and medications we briefly talked about already, but other direct cancer treatments can add to fatigue. And that's why it's so important to be judicious and discuss goals of care when it comes to high burden treatments. So we talked about steroids, that they may improve appetite, but they do not actually help the sarcopenia and can cause myopathy. There's no clear evidence on progestogens, fish oils, and NSAIDs, although all of those often are used if people go to actual cachexia clinics. And artificial nutrition we talked about, it's rarely indicated or effective, and this often causes complications. And the last point I really want to make is comfort feeding. And this probably applies to people later down in the track. And it may be neurodegenerative that people have very poor oral intake, but it's not terminal, or maybe in a near terminal cancer patient. But reminding people that comfort feeding. So the issue with feeding at risk is that, especially in places like care facilities, is that people don't want to take the risks, and people don't end up actually being offered support to eat. So it actually does become important to define to families and the patient that yes, there are no restrictions, so to speak, but people may need assistance. It is on the request of the person. So if they're not actually hungry or they're not asking to eat, then we don't actually push the food, and that it's important that it's not causing coughing, and that it's not related to volume of intake. So we're not aiming for a number of calories, so to speak. So we're moving on to the next clinical scenario, which is you get a letter and phone call from Banksia nurses and requesting what we call anticipatory prescriptions and orders for injectable medications. You found out that she's had another emergency presentation with nausea and vomiting, with the CT showing bowel obstruction, but she didn't want a nasogastric tube and didn't want to stay in hospital. Came home against advice with instruction to return to ED if not managing at home. So her nausea and vomiting has resolved since. Her son decided to take a phone appointment with you as it's too hard to come to the clinic now. So what would you advise her son? What else would you like to know and do? Really, in addition to talking to the son, I think talking to Banksia will be also very important. if Banksia is not already involved. And people with risk of malignant bowel obstruction benefits from additional planning. So this is where really, if people want to stay home and receive best possible care, we definitely want the GPs to work together with the community palliative care services. And because the community palliative care services will be visiting regularly, keeping an eye on the symptoms, but also have a 24/7 number for the patient and the family to ring if there's any new changes, because we don't know when she'll block again. So a bit more about bowel obstruction. 10 to 28% of patients with colorectal cancer develops it. But ovarian cancer, of course, as we know, can develop it as well. And breast cancer and melanoma actually closely follows ovarian cancer. In terms of pathophysiology, there is potentially mechanical obstruction, but also perhaps from inflammation and edema and adhesions, could be from fibrosis as well. And sometimes there are things like lenitis plastica, so actual infiltration or intramural infiltration, and that impairs the mobility, the peristalsis completely. So, and yes, they can be literally inside the lumen. Small bowels, so large bowel tumors are less likely to block. But of course, people often have metastases elsewhere as well. So when I say less likely to block, I should say a blockage from a large bowel tumor, colonic tumor, is less likely to cause vomiting. Yeah. There are other motility disorders, of course. It varies, depends on the level of obstruction. But generally, the vomiting predominates much more than nausea, and distension, again, if it's lower down, like if it's a gastroesophageal junction or even gastric outlet, you may not have much distension. But if a malignant small bowel obstruction, suddenly you'll be distended. And their pain, the pressure from distension or colicky pain from bowel contractions. And there's also a spectrum of constipation. So essentially, you would hear about the usual, I guess, standard management of for survival for bowel obstructions, and that is IV fluids, NG decompression, keeping them nil by mouth, potentially having surgery, and managing the symptoms in between. But not all of them are maybe appropriate at the time. So often the way we think about these is we split it into different categories. Because of course we know opioids are constipating and can add to nausea. The antiemetics, things like metoclopramide, might cause additional colicky pain. You have the again things like antispasmodic or buscopan, which is also anti-secretory, again adds to constipation. So what do we do? And really we just do everything at the same time. So if they have pain, we use opioids, and we do not hold back because of constipation, because we will deal with the constipation. And in that, it may be we just evacuate from the rear end, because of course, if they have a full bowel obstruction, that things are not going down anyway, and that we just evacuate whatever is there from the backside. The anti-nausea, yeah, we just use as much as required, and the anti-secretories depends on if they have NGT in, you probably don't need much of it. But if they don't want the NGT, or if the NGT fails out, then they don't want to go back to hospital to reinsert it because the trip to hospital is just too much, or they might die on the way. then that's when anti-secretories needs to be available to manage. Dexamethasone is interesting. There's a trend towards chance of resolution with dexamethasone given regularly in this instance, but it's not, it's not a game changer, so to speak. That if people are wanting to stay at home and we're not able to source injectable dexamethasone, it's not something I would feel people are severely missing out. And we actually, if people do still want to have something by mouth, people do. They often do need mouth care anyway, because yes, even though everything's going into the gut, they're still dry overall and often have a dry mucosa. In terms of parenteral fluids, look, when the bowel obstruction is not resolving, the fluids actually pull back into the gut anyway. So there's no, just remember the natural secretion, there's 2 liters of gastric juice at least, and overall 5 liters natural secretion into the gut. That gets resolved in large bowel, that won't if it's blocked. And if we put it in the skin, they will just go naturally back into the gut and still won't get resolved, and will come back out through the mouth. So we don't necessarily use parenteral fluids, and we certainly do mucosal care. And yes, surgery needs to be carefully considered, because people need to be able to heal after their surgery. So she went on and had a visit from one of the Banksia palliative care physicians, and we rotated her opioids to fentanyl patch. And that's just in the preparation that if she blocks again, then we don't have to rush around and source additional injectable medications. Note that I said additional because we should have some in the house just in case. But the fentanyl patch can continue to deliver and meet her opioid requirements. She obstructed after a few weeks, so she started to have a continuous subcutaneous infusion of haloperidol and buscopan. And she did actually then went back to ED and had an GT inserted, then came back home again. She became backbound from this time on, and bed-based care was set up and provided by roster family members. Buscopan was removed because of the dry mouth, but because when her NGT accidentally pulled out a week later, it was reintroduced to reduce her vomiting. And she was able to hold conversation until the last day and died after 24 hours of becoming unconscious. So in summary, the take-home messages: constipation prevention with prescription laxatives is often required for people living with life-limiting and threatening illnesses, especially in setting of regular opioids. And that select antiemetics based on underlying symptom mechanism and side effect profile is very important. Fatigue is often multifactorial, often refractory, and energy conservation as well as equipment provision is crucial. Always maximize protein and energy intake, and generally avoid fiber in this setting. And people with risk of malignant bowel obstruction benefits from additional planning. So quickly, some administrative support in the sense that for referral to community palliative care, if you're in the Banksia catchment, which is in the Shire of Wittersea, Shire of Nillumbik, or City of Banyule, then you can just just call us or visit our website and follow a link to make a referral. If you're not in the Banksia catchment area, you can find your local service by keying in the patient's postcode on the Find the Service Near You on Palcare Victoria website. So not your clinic's postcode, but the patient's postcode. Sometimes you'll get, because some suburbs actually has 2 overlaps, but yes, we will refer to each other or redirect referrals if required. In fact, we do that quite often. Very quickly, very important to remember that there are trial opportunities for these. I think the medicinal cannabis is a big one, and there's one run from Austin directly, but you can also access any of these trials through banks, yeah? And I'll be handing over to Crystal for our health pathways discussion.
Hi, thank you very much. I'm just going to set up my screen here. Okay. Hi, everyone, and welcome. I'm just going to do a quick overview of Health Pathways here. We're having some slight difficulties here. Okay. Health Pathways Melbourne is an online resource that's been, it's a collaborative online resource developed by Eastern Melbourne and Northwestern Primary Healthcare Networks in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways Melbourne provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare professionals in delivering consistent, evidence-based care to their patients. This presentation will demonstrate how to access and navigate Health Pathways Melbourne to find relevant pathways on palliative care and symptom control. Navigating Health Pathways. Visit the Health Pathways website and log on. You can search for the relevant pathway by using the search bar located at the top of the page, or enter by entering relevant keyword like nausea and palliative. Alternatively, you can use the table of contents on the left-hand side of the page. You'll find more than 40 pathways within the palliative care suite. You can select the pathway that matches your search. A clinical editor's note is a concise temporary edition by a senior clinical editor. It informs healthcare practitioners about developments in the wider health system or community. It enables users to swiftly access significant new or changed information that directly affects user practice. As can be seen here, with the palliative care access to core medications and a locator. The assessment section is a concise list of steps users may consider taking to diagnose and evaluate the severity of a patient at the point of care. Drop boxes throughout the pathway provide supplementary information. The management section is a succinct list of steps users may consider taking and includes additional information needed to execute these steps and links to referral options. This section also provides links to relevant extended information that the clinician may wish to consider, shown here with the pharmacological and non-pharmacological options. This section includes locally relevant requests and referrals that the clinician may request from a third party for their patient, and provides information on the clinical criteria required for each option. The information section at the bottom of the pathway provides a selective list of links to useful information specific to health professionals and patients. As mentioned before, there are 40 palliative care pathways, which includes clinical referrals, resource pages, and resource pages. This slide provides a list of relevant and related pathways for symptom control in palliative care, local community palliative care providers, palliative care service referrals, and resources. And continuing on to general palliative care guidance and assessment, emergencies in palliative care medication, and essential conversations. To access Health Pathways Melbourne, go to the website at melbourne.healthpathways.org.au. It's available to general practice teams and other clinicians in the Eastern Melbourne and Northwestern Melbourne PHN. If you don't have access, you can just click on register, which brings up an online form, and we can organise an automatic login for you. Otherwise, you can email us or use a QR code on your screen. Thank you.
So I think we have 3 minutes for Q&A, and I don't think anything's typed into the questions yet. Yeah, Lisa, do you feel there's something I've missed that you specifically wanted to comment on anywhere there? I think the big one, I think that's not black and white, is how to counsel families who, often comes in and stressed that their relatives are not eating enough, or sometimes it's the person themselves who are not eating enough, and I'm sure you see this quite often. And do you have like a personal spiel that you use?
I do have a personal spiel, but what I think is really important in particular is the GP relationship and the ability to build rapport. And so because you guys have obviously seen clients over a period of time, usually much longer than us, those conversations might be better off coming from, somebody that they know and trust. So in the palliative care setting, we're generally needing to really hone in on our rapport building skills in a short amount of time in order to be able to have these effective conversations. So I think that's an advantageous aspect of having a long-standing and great relationship with the GP.
Yeah, I think another common question really is the fluid aspect, I think, and in terms of parenteral fluids and things, because it is possibly even more in hospitals, of course, because we don't really do parenteral fluids at home. Hospital and home is a very different setup, and of course have very different aims in using parenteral fluids, which is not actually being identified to help symptoms of dehydration much in the palliative setting, as discussed, because often they have reasons why the fluids do not go to the right place anyway. Thank you. So there is a question whether Targin help as the opioid. Yes. So yes, in the sense that people do have less constipation on Targin. Saying that, though, often people still need to have some laxatives, so they still need to work out how much laxative they need, because opioid is not the only factor that leads to constipation. And Targin, as we know, when there's liver impairment, the naloxone can actually interfere with analgesia because they spill into the systemic system. So yes, it's a double-edged sword, really. Saying that, though, things like fentanyl is very helpful if we know how much opioid they need, because the downside of fentanyl is predicting how much is being absorbed, whether it's going to stick on all the time, and that they come in big chunks of patches that some people don't need 12 mics, which is oral morphine equivalent of 30 milligrams at a time. So yes. Great, very excited to have questions. All right, I think that's the end of the session. I'll hand back to Nicole.
Thanks for that. Wonderful. Thank you all for being a part of tonight's session. It has been an absolute pleasure to have you here this evening. I hope you've taken away some valuable insight, and I'd also like to extend a special thank you to all of our exceptional presenters for their fabulous work. By participating in tonight's RACGP accredited activity, you will receive 1 hour in educational activities, and I will lodge those hours on your behalf through the RACGP. At the end of this session, a link to the workshop survey will appear on your screen. Please do take a moment to fill the event survey for your accreditation and to provide valuable feedback so that we can further improve these education sessions. Your responses are greatly appreciated. This is a 5-part palliative care in the community series. If you haven't already done so, please register yourself for the next session, conducting essential conversations with palliative patients and their carers. It is being held on Zoom again, Thursday, the 26th of October from 7 p.m. to 8 p.m. This is another RACGP accredited session. Please scan the 3rd QR code to register yourself for this virtual education activity. Please also take a moment to check out other upcoming MPhEN education events by scanning the middle QR code on the screen. It will take you directly to our events page on the MPhEN website, where you'll be able to find out more information about other education workshops we have coming up. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you have seen tonight, in addition to other relevant resources. You will also receive your certificates within the next 4 weeks of this session, and that'll come from MPhEN. We thank you all for your time and attention this evening. That is all from us, and I hope you have a wonderful rest of your night. Thank you all.